So a glioblastoma is a malignant primary brain tumor. Glioblastoma is particularly difficult to treat compared to other types of tumors that grow in the brain for a number of reasons. One is that the tumor is very aggressive, and so the treatments that we have, even treatments that work well for other types of tumors, aren't permanent treatments in glioblastoma. Glioblastoma initially starts from cells that are normal support cells within the brain. These cells begin to grow and to migrate throughout the normal brain. And a glioblastoma tends to infiltrate the normal brain like spies infiltrating. So you have a tumor cell that's right next to a normal cell. In order to take out the tumor cell, you'd have to take out the normal cell next to it.
The most common and typical symptoms that patients present with a brain tumor include headaches, nausea, vomiting, or a specific area or pattern of weakness or new sensory symptoms. Another very common presenting symptom is a seizure that brings a patient to urgent medical attention.
There's nothing that the patient did to cause it, and there's nothing that really you could have done to have gotten the diagnosis any earlier. It happens sometimes. We're still understanding why the patient has the tumor, why in this part of the brain, and why at this time.
A treatment plan really is something that is thought of in a very meticulous fashion. That typically means we, as the neuro-oncology team, will address the chemotherapy piece, and the radiation oncologist will address whether radiation is appropriate, and the neurosurgery team would address the neurosurgical options.
When thinking about how to approach a glioblastoma and what treatments are the most appropriate, it's important to take into account how well a particular treatment will work and what effect that will have on the patient. So at the time of review of the patient's imaging, then we determine if surgery is a good option for the patient. That decision is made through a combination of how much of the tumor do we think that we can safely get out without hurting the patient or having a new deficit after surgery, and also if we think that the patient can tolerate the surgery in terms of their general health and well-being. Once the decision for surgery is made, we have a lot of adjuvants in the operating room that help us to be safer, more accurate surgeons. And that includes navigation systems that help us to ensure that the entirety of the tumor is taken out where we can do that safely. Intraoperative imaging adjuvants so we can actually better differentiate the tumor from normal brain. And colleagues in neurology who are giving us real-time feedback about how well the brain is talking to the body and vice versa as we're doing the surgery. When a tumor involves a critical part of the brain, such as the language areas where we want to receive real-time feedback about how the patient's language function is stored and what is safest to take out in terms of the resection of the tumor, then we ask the patient to be awake during the tumor resection part. The patient is sleeping very heavily before without a breathing tube to assist them with breathing, with very specialized anesthesia that's done with a team that we work with regularly where we do this all the time. The patient is given medication to remain comfortable during that time and is able to communicate with us and give us real-time feedback. At that point, we can use both the neuronavigation, the inspection of the brain, what we see with the microscope, and also real-time feedback on stimulation of the brain tissue itself to determine what the underlying function of the brain is. Neuronavigation is like an intraoperative GPS system, such that we can tell in three-dimensional space where we are at all times. That allows us both to make the smallest opening in the skull that we can and to ensure that we completely resect the part of the brain that we think is involved with tumor. This navigation system helps us to have more reliable and complete resection of these tumors.
After a surgical specimen has been obtained, whether that be a biopsy alone versus a complete or partial resection, we allow for the surgical wound to heal before then offering a patient chemotherapy and radiation. Chemotherapy can be in the form of an oral-based chemotherapy called temozolomide, and that is used at the same time as radiation. The timing of the length of treatment is dependent on each individual patient, And then we also have clinical trial options that might be layered on top of standard therapy.
So radiation therapy is a way of using electromagnetic radiation, usually X-rays and sometimes other forms of radiation like protons, in order to kill tumor cells. So radiation therapy for brain tumors and brain lesions usually involves what we call external beam radiation therapy or stereotactic radiation treatments. Stereotactic radiation or stereotactic radiosurgery is typically delivered in 1 to 5 sessions, and patients who have smaller tumors typically can be amenable to this type of radiation treatment.
Since we are an academic institution, we really want to offer our patients a thorough platform of clinical trial options so that they can consider this as a form of therapy should they choose to want to be a part of the trial. The benefits of a trial are that these are often the newest forms of therapy and kind of the cutting edge new advances within the neuro-oncology world, and we want to be able to offer that to our patients. Every clinical trial will have a list of eligibility criteria, so we do try to pre-screen our patients before they even come through the door to understand whether they might be eligible for a trial and therefore offer those trial options when appropriate. But there are certain cases where the trial might not be something that they qualify for, and we would then be able to offer standard forms of chemotherapy.
So when I discuss with the patient the possibility for surgery, I discuss in detail the risks, benefits, and alternatives of surgery. So the risks of surgery need to be outweighed by the potential benefits in order for us to continue and proceed with the surgery itself. Some complications that are specific to brain surgery that can be problematic would include a bleed either during the surgery or immediately after that may require an additional surgery. Other complications could include a seizure, either before or after the surgery, a need for an additional surgery, incomplete resection of the tumor, or a new neurologic deficit that the patient didn't have prior to the surgery.
Because brain tumor patients might be affected neurologically, we do work very closely with our colleagues within the therapy space and rehabilitation space. Those would include occupational therapy that really targets tasks that are really important to their everyday living. Physical therapy might be more important when somebody is affected with regard to their balance or gait or walking. Speech therapy when language is affected, both in expression of language as well as the comprehension of language. And those therapeutic modalities are very much a part of what we do, especially in the post-operative setting. The world of neuro-oncology is evolving at a very rapid pace, and we're very fortunate to be at a time when we can offer our patients both standard therapies as well as new, novel techniques for imaging as well as therapeutics and treatment.
I think it's very challenging when you're met with a diagnosis like glioblastoma, how to put everything together. And my reassurance is that if I had a family member or a friend who had this disease, I would want them to be treated here with us, because I think that we offer the most complete and cutting-edge technology that will give them the absolute best chance to have the best quality of life and treat the tumor simultaneously.